Season 1 of Medsplaining is brought to you by Estee Lauder. With 40 years of night repair expertise and 30 years of collagen research, Estee Lauder are the experts in nighttime skincare. I'm Dr. Jennifer Zelovitzky. Welcome to Medsplaining. When I wanted to become a doctor at age 35, I thought I was too old, but I did it anyway. I'm so glad I didn't let my age stand in my way. And now I actually think going to medical school when I was 35 made me a better doctor than I would have been when I was younger. And now I want to hear from you. What did you do even though you first thought you were too old? Maybe you changed careers too. Or maybe you ran a marathon when you'd never been a runner before. Maybe you became a mom when everyone told you were too old. We want to feature you in an upcoming episode of Medsplaining, so please send your stories to medsplaining@gmail.com and you could be featured in an upcoming episode and win a $450 skincare gift set courtesy of our Season 1 sponsor, Estee Lauder. I'm really excited about today's episode featuring Dr. Toni Zhong. She's going to talk to us all about our breast health, advocating for ourselves as women, and the new breast cancer guidelines. But first, wake up to your best skin yet with Estee Lauder's Advanced Night Repair Serum. Formulated with their exclusive night peptide, it helps ignite 7 powerful skin renewing actions, fighting the key signs of aging, all while you sleep. Transform your skin overnight with Estee Lauder. And there's more. Until December 15th, Medsplaining listeners get 15% off their entire order when they shop online at esteelauder.ca. Enter the code DrZ15 to get 15% off your entire purchase. That's DRZ15 at esteelauder.ca. And now let's dive right into this episode with today's Quick Six. So the what today is breast health and breast cancer. Who? Well, breast cancer can affect anyone with breast tissue, including about 300 biological males in 2024, but it overwhelmingly affects women, with 84 women diagnosed every day in Canada. Where? Well, breast cancer often develops in the milk ducts or milk-producing glands of the breasts, and 50% of breast cancers are discovered in the upper outer corner of the breast, where the tissues are denser. When? Breast cancer is most commonly diagnosed when a woman's in her 60s, followed by her 70s and then her 50s. And although it's still relatively rare, women are being diagnosed increasingly in their 20s, 30s, and 40s. Why? Apart from age, the major risk factors for the development of breast cancer are genetic mutations, having fewer children, having denser breasts, family history of breast or ovarian cancer, previous radiation therapy to the chest, obesity, high-risk alcohol intake, smoking, or vaping. How? Well, how to get screened for breast cancer in Ontario. And as of October 2024, women including non-binary, trans, and two-spirit people between the age of 40 and 74 can self-refer for a mammogram every 2 years. No doctor's referrals required. Talk to your doctor, nurse practitioner, or beginning in the fall of 2024, call Health 811 to start the conversation about screening for breast cancer, including the risks and the benefits. Talk about your own personal values and decide if screening is right for you. All right, we're about to meet today's guest, but first, discover the transformative power of Estee Lauder's new Revitalizing Supreme Night Power Bounce Cream. Clinically tested to reduce lines, this moisturizer provides elasticity, bounce, and oil control. Wake up to beautiful, revitalized skin in just one night. And there's more. Until December 15th, 2024, Medsplaining listeners get 15% off their entire order when they shop online at esteelauder.ca. Enter offer code DrZ15 to get 15% off your entire purchase. That's DRZ15 at esteelauder.ca. I am deeply humbled by today's guest, Dr. Toni Zhong. She is a true rock star in the world of women's health. She's the clinical and research director of the University Health Network Breast Reconstruction Program here in Toronto, an associate professor in UofT's Department of Surgery and Surgical Oncology, and a passionate advocate for breast health, to name only a few facets of her remarkable career. Today, we will take a deep dive into the prevention, detection, and treatment of breast cancer, including the brand new Ontario breast screening guidelines. Toni, thank you so much for being here. I'm so happy we could make this happen because you are a guest I've been desperate to get on this program to talk about all things breast health. And before we dive into that, why don't you tell us a little bit about yourself, your more outside your career? What do you like to do for fun? What does your life look like when you're not in the hospital?
It's a pleasure to be here. Thank you so much for having me. So my name is Dr. Toni Zhong. I'm a plastic and reconstructive surgeon at University Health Network, where I've practiced for the last 15 years. I'm also the clinical and research director of breast cancer reconstruction there. So that's what I do professionally. Mm-hmm. And then there's me personally. So my husband is also a plastic surgeon. So together we lead a very busy life with 2 young kids. We have a son who's 12, who keeps us very busy going to and from hockey. So I am partly...
It's mandatory.
It's mandatory.
He's Canadian. He has to. They won't let you off the hook there, yeah.
Exactly. So I'm a hockey mom. I'm a soccer mom. Mm-hmm. And then we have a 9-year-old girl. She keeps us very busy too. And then I would say recently I've started developing this love for racket sports. So you might find me playing tennis, pickleball, sometimes at 6 a.m. when, the sun is just coming out.
Of course. Yes. And you're enjoying it. Did you gravitate from tennis to pickleball? Because I'm a pickleball widow, as I call myself now, because my husband's plays pickleball. He's obsessed. He plays it every minute that he can.
Oh, that's so funny. You know what? I have been a tennis player in the past. I think I played for our high school team very, very long time ago. Mm-hmm. And then I just rediscovered my love for tennis. And then pickleball is just so social. So I started getting invited to play pickleball. And then there's just the social element of it, which is very nice. But I love just being active and having something outside of work and outside of driving kids. I think that's important to balance.
Absolutely. That's fantastic. And, we're here. It's October. It's a very exciting month for those of us who are on sort of the front lines of women's health, because this is the month where in Ontario, the breast cancer screening age drops from 50 to 40. I know that
finally.
Yes. You have been very, very vocal, a huge proponent of doing this. Can you tell us a little bit about the rationale for dropping the minimum screening age?
I love talking about this, and thank you for asking me. So this is highly anticipated, and the government has said that this will begin in the month of October. So the rationale for this is really multifold. So I would say, let's say just from an epidemiological perspective, we have great studies that show us that the annual incidence of breast cancer has been increasing for women in their 40s. So between the years of 2015 to 2019, the annual incidence of breast cancer has increased by 2% in this age group, climbing to the point now where in Canada, we know that 17% of breast cancer occurs in women in their 40s. That is a significant portion of women who are affected in their 40s. So we can no longer ignore this, I think, important and staggering statistic. Yes. And there's no biological reason why we need to postpone until 50. So I think it's a complete myth that we need to dispel, that breast cancer only occurs in women who are older. That's not true. So second of all, I think that there's been a lot of great research in the area of health services disparity. So for example, we also know that the peak incidence for breast cancer in white women is in their 60s. And that's where I think a lot of the older data was based on. Mm-hmm. But in women of different ethnic backgrounds, like Blacks, Hispanic, Asian women, the peak incidence for breast cancer is actually in the 40s. Mm. So again, biologically, we need to be more cognizant that we're talking about various different populations of people. And also, no matter how good treatment for breast cancer has evolved, and it is amazing. All the discoveries and all the personalized treatment of breast cancer has made prognosis much better for women diagnosed with breast cancer. But the single most important prognostic factor is the stage of breast cancer when you're diagnosed. So if you're not screening, then women are diagnosed at a later stage. And we actually know that from very large Canadian observational studies. And so if you're upstaged because you're not being screened and not detecting breast cancer earlier, then your prognosis is worse, your mortality is worse, and never mind the more invasive treatment that women have to endure and the years lost to treatment that may be avoided if you were diagnosed in an earlier stage.
That is such a good point. And women are terrified of breast cancer. And I keep mentioning this is you do not require a family doctor's referral to access screening mammography in Ontario. I think it's really important because we've all heard these horror stories about a family doctor acting as a gatekeeper. And I've just seen it too many times where the woman was told, you're not old enough. They don't ask about family history. They don't ask they don't think about ethnicity. They don't think about the fact that the original guidelines are based on the way humans lived, 40, 50 years ago. And we live very different lifestyles now. We see obesity increasing. We see alcohol and substance use increasing. These are factors that are there are risk factors for breast cancer as well.
Absolutely.
So we have to make sure that our guidelines are keeping up with what we're seeing in real life and out there in society. And so another thing that's really evolved over time is the recommendation towards breast self-exams. I remember when I was doing family medicine, it was very clear we were told, stop telling people to self-examine. It's leading to a lot of unnecessary ultrasounds, mammograms. They're finding things. They're very anxious. The vast majority of these lumps and bumps turn out to be benign. And yet, I always had this spidey sense in me that it was not the right approach. We shouldn't ignore our breasts. So what is your philosophy? Where do we meet in the middle between avoiding unnecessary anxiety and staying on top of our breast health?
So you just brought up so many good points. So let's try to touch on as many as you brought up. So you talk about anxiety. And first of all, a big disclaimer is that performing self-breast exam still remains contentious in the medical community. So like you say, same with me, when I was going through medical school and when I was going through my plastic surgery residency and training, the guidelines were, don't tell patients to do self-breast exams because it causes too much anxiety for those women and it can lead to false positives. So here I am going to go on record and say, let's first discuss anxiety. Well, there are different kinds of anxiety, right? So there's the transient anxiety when you found something that's abnormal in your body. You don't quite know what to make of it or how to follow up on it. Yes, there is, of course, anxiety when you've discovered that something may not be right, that you need to seek investigation or some sort of professional consultation. But then there is the anxiety of being actually diagnosed with breast cancer because it has been found late and because it may have spread to the lymph nodes. And now you're being told by your doctor that you might need chemo, you might need a mastectomy followed by radiation, and that you're stage 3 or 4, where your prognosis may be 50% or less. So which anxiety would you rather? For me, I would rather the transient anxiety of, I found something maybe abnormal. Let me pursue this because I'm an educated and self-aware person that I want to do something about it to make sure that it's actually okay. Rather than the anxiety because I've found something, now I am having to confront with an actual cancer diagnosis. And then there's this whole talk about false positive. So let's stop telling women to do self-exam because it leads to false positive. Well, you and I know false positive in medicine means that you're diagnosed with breast cancer. You've been told that you have cancer, when you don't. That's a false positive. But what I think people are talking about is recall. So if you found something and you've now been ordered an extra investigation like a mammogram or ultrasound, and they found something that they're like, this may be abnormal, or we don't know if it's abnormal, so let's follow up with another investigation, but please come back because we don't want you to be lost. We want to investigate this using another modality.
Right.
And so the extra callback, so that's like a recall or callback. That's not a false positive. And that's what most people say. So most people that say false positive, it's not really a false positive. Nobody's been given a cancer diagnosis when you don't have cancer. People have been simply said, you need to come back for extra investigations. And I'm okay with that transient anxiety of having extra investigations to make sure that my body's in the clear. And I would say that most of the women that I talk to that are in our community probably feel the same way. And so back to doing self-breast exam. I think people that say, well, it leads to this or that, and women don't really know how to do self-breast exam, so stop telling them to do it. I think that is not the right approach. The right approach is, let's teach women how to do it properly, when to do it, so that you know what you're looking for. And most importantly, the more that you practice it and know what you're looking for, then the more you're aware when something is different or something is wrong. So I think that is the more logical approach than say, abandon it altogether because you've done it once and you don't know what you're doing.
I'm so glad, because you validate what I've been telling women all along, which is not, there's a big difference between telling someone, go look for lumps, and telling someone, choose a time of the month, maybe right after your period, when things are pretty stable and calm.
Exactly.
And just check and make sure everything feels the way it always feels. And then if something is there that wasn't there before and it's persistent, that's a time to go get checked, right? And
Exactly.
I think that's an empowering thing rather than an anxiety-provoking
I think it's
approach.
empowering when you teach people how to do it properly. I think when you say, just stop it, you don't know what you're doing, I don't think that is good practice. And I think it is important, like you said, to do it at the same time. So I usually tell people about 7 days, even 10 days after your period.
Perfect.
So that's usually when the breasts are most quiet.
Okay.
Do it in a quiet place. And also, don't expect that you're going to know your body that well after the first or second time, but do it at the right time every month and start practicing it when you're in your early 20s. So by the time you're in your 30s and 40s, it just becomes routine. And I think this is what we should be telling our patients, and we should be teaching them really how to do it properly.
So how do you do a proper breast exam?
So I always tell everybody that, choose a place, but most times it's a well-lit place in the bathroom where you're in front of the mirror, and you first start with inspection. So you want to look at your breasts from the frontal view. If you're large-breasted, you also want to lift up your breast so that you see the undersurface. And then when you're inspecting, you're looking for any changes in the skin texture. And any retraction of the nipple or retraction or dimpling of the skin, or even discoloration on your skin. Sometimes you can have an orange discoloration that is in a more rare form of breast cancer. And then you want to turn yourself to the side so that you see the side profile and look to see if the sides of the breast, there's, again, any skin changes. And then you move on to the palpation part. You want to use the finger pads of your middle 3 fingers, and you want to go in a gradual circular motion all over the surface of the breast. And you do it in a very systematic fashion. So nice and slow, and you want to use 3 different pressures so that you feel lightly just under the skin. With moderate pressure, you kind of feel deeper into the skin, and then deeper pressure, so that's closer to where the chest wall is. And you kind of go up and down, like mowing along, we say. And don't forget to check under the nipple because that's a common place for finding breast cancer. And then also in the upper outer quadrant of the breast. And then don't forget to also check under the armpits because that's where the lymph nodes live. And you just want to gradually palpate to see if you feel any lumps or bumps and any firm nodules.
Okay.
So you do this with both sides of your breasts.
Okay. And one of the other reasons that I commonly hear women are afraid to get a mammogram or don't want to have a mammogram too often is there's a fear of the radiation involved. So can we dispel this once and for all? Should women avoid mammograms or avoid annual mammograms because of radiation?
So excellent question. And you should not avoid annual or biannual mammograms because of the fear of radiation. So radiation is measured in this unit called millisieverts. And it's a mammogram, a 2D mammogram is 0.4, so you're on a long flight, like a transatlantic 10-hour flight. That's taking 4 of those flights. And a CT scan or X-ray of the spine, those radiation exposure is much greater than a 2-dimensional mammogram.
Perfect. And another quick question, hopefully, to dispel another myth. Should people have thermography instead of a mammogram in order to avoid the radiation altogether?
So another really good question. Thermography is a new thermal imaging technique that's based on temperature and blood flow. Mm-hmm. So there's a lot of fascinating research about thermography and the use for cancer detection. Now, for breast cancer, it can be used to, let's say, use as an adjunct imaging. But it's not first line. Mammography is still first line because, again, there's in situ breast cancers where mammogram detects calcifications. And that can be sometimes the earliest sign of in situ breast cancer. And that is not associated with temperature change or blood flow. So thermography, there's a lot of potential for other cancers, but not in breast cancer.
I think that's really important because that's something that you see often on social media. And we want to really make sure people have all the information they need to make the best decision for themselves. So I've read conflicting things about the use of ultrasound for women with dense breasts. So we've all seen, the callback where the breasts are very dense. Mm-hmm. We recommend an ultrasound to identify any nodules or masses we might have missed. And then I've also read, that might only increase the detection by about 3%. So what is your take on the use? When should a woman advocate for themselves to have an ultrasound?
One that I think is not really well understood and probably needs more research as well is breast density. So in addition to, I think we talked about... I
want to say shocking that something to do with women's health needs more research.
Yes.
I'm going to take a minute to recover from that. But go ahead, go on.
But breast density is a relatively newer topic. So for example, when I was studying all this in medical school and residency, and maybe you too, we didn't understand that breast density is such an important risk factor. Mm-hmm. And the reason breast density is in our conversation and we're talking about it today is because it is a major risk factor for women developing breast cancer. And it's important for 2 reasons. First of all, it's important that you know your breast density because if you belong in one of the categories of higher density or the highest type of density, which is density C or category D, you're at increased risk for breast cancer because it just means that your breasts are more full of glandular tissue than fat. Breast cancer develops in glands or ducts, not in fat. Second, the big reason why it's important, and you're talking about perhaps other investigations in addition to mammogram, is that if you have higher density breasts, well, first of all, on mammogram, dense breasts, so glandular breasts, it looks white on mammogram. Breast cancer on mammogram also looks white. So it's very difficult to see white on white. It's like a whiteout. So you could have a breast cancer that's camouflage. So sensitivity really is reduced for detecting breast cancer when you have dense breasts on mammogram alone. So you probably need another form of imaging if you have more dense breasts. And what that imaging is, I think, is where there needs to be a lot more research. It's much easier to get an ultrasound than to get an MRI, which is probably why ultrasound seems like it's a logical next step. But you're right, ultrasound is also technician dependent. It's not excellent. We do know that breast MRI is probably the gold standard, but also 3D mammogram, where they produce different images and then produces a three-dimensional constitution of the breast. That's also very good. So in addition to ultrasound, there are other modalities that may be slightly better, like MRI or 3D mammography.
And is 3D mammography coming as a standard of care, do you think?
It is available in some institutions. Now, in the US, I certainly know that a lot more places are offering 3D, and it might be a marketing tool. I hope it is coming. And I do think for dense breasts, 3D really has an important role.
Okay. And let's talk on some of the common findings women might see when they look at their breast ultrasound report. And I think two really important things that women need to understand are fibroadenomas and cysts. Yes. Do you mind explaining what they are, what the difference is, and maybe why women should just not worry so much when they see these come back on their report?
Exactly. So cysts and fibroadenomas, and sometimes you could even see a report that a woman has fibrocystic changes associated with breast. So those are all benign findings. And what's a cyst is simply a fluid-filled sac, and they can change with menstrual cycle. Fibroadenoma is a completely benign lesion of the breast. And so if you see reports of that on your mammogram, that is completely normal and it's nothing to be concerned about. And it just means that it's part of we would just say it's in the complete spectrum of benign.
Perfect. Amazing. I also have women who are diagnosed with an early stage breast cancer who come and want my opinion with respect to, do I go with the lumpectomy, meaning just removing the tumor itself, or do I advocate for a mastectomy, a removal of all the breast tissue? What does the evidence show us with respect to the difference in terms of survival outcomes? And how would you, advise a patient or counsel a patient when they're making that decision?
You're asking me some excellent questions. So I spend a lot of my time in my consultations with precisely this scenario. And I think this is in medical school where we learned that there's a science, but there's also an art associated with this. So it's shared decision-making, right? You have to tell the patient, you present them with both the pros and the cons, you discuss the alternatives, and I think together you incorporate their values and their preferences into a decision that is going to hopefully give them a fulfilling outcome. That is always the goal. So I start by saying that if you're diagnosed with early breast cancer, and hopefully most women are, we know that cancer outcomes, so the traditional cancer outcomes that we measure, which is mortality, recurrence at 5 years, 10 years, is actually exactly equivalent between doing a lumpectomy with radiation. So lumpectomy has to go hand in hand with radiation, so that's called breast conserving therapy, versus mastectomy, with or without reconstruction. The cancer outcomes are exactly the same. So then if they're exactly the same, then what other outcomes may matter to our patients? And that could be lifestyle, that could be quality of life, that could be what kind of, invasive versus least invasive surgery they desire. And then I take into consideration things like, do they want to have, more normal breast sensation after? Are they interested in maybe doing something with the other breast to balance? So we really have to take all that into consideration. And then whether or not a patient's own preference with regards to radiation, that comes also into the whole picture. And then sometimes my patients have to go see a radiation oncologist to discuss the pros and cons of radiation, because sometimes my patients are very wary of radiation and they don't want the long-term effects associated with radiation.
Right.
So if you fall into that camp, and then maybe you prefer undergoing a mastectomy with or without immediate reconstruction. And then often I get the question of, well, if I am going to have a one-sided mastectomy with reconstruction, what do you do with my other breast? Am I always going to be asymmetric? And so that's when I say, no, hopefully not. And let's together make a decision about the type of reconstruction that will give you the best match to the other side. And whatever that may be, using your own tissue versus using something like implant. And we can incorporate doing a reduction on the other side, or maybe an augmentation. So all that comes into play. And I think that's all important elements of shared decision making.
So on the topic of, when people come, they're diagnosed with a cancer and they have a mastectomy with immediate reconstruction versus delaying reconstruction. What percentage of women would you say these days opt for immediate reconstruction?
So I think these days the rates are definitely increasing, partly because it is now more mainstream, immediate reconstruction. And also because I think for the last decade, I have to say, I think we have really done a great job of incorporating breast reconstruction into first-line treatment for breast cancer. I'm very proud that this is no longer an afterthought for women. And we've also had to dispel a lot of myths associated with immediate reconstruction. When I first started doing this 15 years ago, there used to be myths like, if you did reconstruction at the same time, you might be delaying somebody to having chemo or radiation. Well, we know that we do it safely so that we don't delay it. And there used to be the myth that if you're having immediate reconstruction in the same surgery, then complication rates are going to be higher, or the risk of breast cancer recurring in the immediate reconstruction was higher. We've also had to dispel that from an oncologic safety perspective. So when I first started 15 years ago, Ontario rates were about 7 to 8% of immediate reconstruction at the same time as mastectomy. And the latest rates that we've looked at through Cancer Care Ontario data is that we're somewhere about 25% immediate reconstruction. And I think that is a good rate, because not everyone's going to want immediate reconstruction. Some people are very happy with just a mastectomy and moving on with their life and reporting excellent quality of life after, which is mastectomy alone. And sometimes patients do have more advanced breast cancer where we, would see them and actually recommend delaying reconstruction until all the cancer treatment is finished. Or sometimes they just may have comorbidities where doing immediate reconstruction may not be the best thing for them at the same time.
Okay. And I've been reading lately about AI being helpful in detecting early breast cancers. I'm wondering if you've been experimenting with this in your practice, or what you see from your perspective in terms of the pros and cons of using AI for the detection of breast cancer.
So I think AI is really coming into cancer care, and I think it's here to stay. I think at UHN, I think I just read a hospital memo that we're starting to have a VP of AI, of research into AI. So AI is here to stay. In terms of breast cancer, where AI has really come into the literature has been detection in terms of reading mammograms. So how good is AI at detecting breast cancers from mammograms? And so there has been, I think, published recently in the Lancet, an excellent RCT comparing AI versus double reading. So 2 qualified breast specialists, radiologists, reading mammograms. And it showed that AI was definitely more efficient than obviously 2, breast radiologists reading through all these mammograms. But safety, they also proved safety. So it was equally good, if not slightly better, than breast radiologists at detecting breast cancer. The biggest thing is it reduced the workload for the radiologists, which I think presents a very important advantage when we're talking about what we talked about earlier with rolling out breast cancer screening to women in their 40s rather than 50s. A big criticism is, well, that's going to overwhelm the system. Where are you going to find all these radiologists who are reading this? Well, maybe AI can, help reduce some of that workload.
Right. That's a really good point, because everyone in the healthcare system is overburdened. We want to make sure we're assisting, but not replacing.
Exactly.
Because I think there will always be a role for humans in medicine, because we know there are so many nuances, and you have to take patient factors into account that maybe wouldn't be known to an AI, technology or something like that. I want to delve into a bit of a controversial subject, if you will. It's where your career and my career sort of intersect, which is in terms of, women go through breast cancer treatment, and often this throws them into menopause through their chemotherapy. If they have to have an oophorectomy because their breast cancer is genetic, for example. And women have been told for decades that once you have a diagnosis of breast cancer, you must never, never, never consider hormone therapy. And I believe this stems from the fact that breast cancers are described as estrogen receptor positive, progesterone receptor positive or negative. And this leads to a lot of confusion, because we have a lot of very good data that shows that estrogen therapy does not cause breast cancer. However, it's a very, very controversial subject. And I'm wondering what you see from your perspective in terms of when women come for follow-up. How are they feeling? What are they being told? And how is their quality of life?
I think that you're absolutely right. So women who have had to have endocrine therapy or hormonal therapy or chemotherapy, let's say in their 40s or 50s, are suddenly, in probably a span of a couple of weeks, thrust into menopause, when usually, biologically speaking, menopause takes 5 years or years at least before the symptoms are full-fledged, manifested. So I can't even imagine going through menopause in a span of 2 to 3 weeks. And I think that leaves our patients feeling truly terrible, right? So my patients will tell me that it was easier to recover from a bilateral double mastectomy with reconstruction, where I used tissue from their abdomen, and their surgery was 10 or 12 hours long. And they went through recovery for 8 to 10 weeks where they can't lift anything heavy, do anything strenuous. They will say that was far easier of a recovery and far easier to tolerate psychologically and physically than what the hormonal therapy, endocrine therapy, or chemotherapy has done to them. And so there is no doubt that that kind of therapy, as good as it is for treatment of breast cancer, we think, it has a significant negative impact on a patient's quality of life, their sense of well-being, their productivity. And I think it is an area that has been often neglected. And I think you're right to say that everybody who's ever had breast cancer is not a candidate, or hormone replacement therapy is a contraindication for every single one of these individuals is a blanket statement that does not apply. I think we're getting better at personalized treatment of breast cancer with offering targeted therapy. And as you mentioned before, now we know that there are many different subtypes of breast cancer. We routinely, everyone gets tested for estrogen, progesterone, HER2 receptors, which are proteins that are expressed by breast cancer cells. And knowing what protein receptors are there, knowing what feeds into these breast cancers. So what you're referring to as estrogen positive, progesterone positive breast cancers, those are more common breast cancers. And so, yes, We do know that if somebody is estrogen or progesterone positive, we give them anti-hormonal therapy. So very common, tamoxifen, letrozole, to reduce the estrogen in their body so that less estrogen gets to these receptors and the breast cancer is less likely to come back. So that does work, and we know that to be very, very effective. But to say that if someone had triple negative breast cancer, so in terms of their estrogen progesterone receptors are negative to those hormones, and they should not be having hormonal replacement therapy, even if they have horrible postmenopausal symptoms. I think that's an area that really begs research.
And we know for sure that women, even with estrogen, progesterone receptor positive breast cancer, can safely use vaginal estrogen. So many are suffering with symptoms of vaginal dryness, discomfort, recurrent UTIs, inability to have sex. And these are things that are really affecting their quality of life. And we know that that is safe. We also know there are many non-hormonal forms of treatment for those hot flashes, those night sweats. But I also think that there needs to be a lot more investigation done as to the true link between estrogen and the development of breast cancer, because we know that the risk of breast cancer increases with age, and yet estrogen levels decrease with age. So clearly there is a mystery to solve here. There are times when we have a lot more estrogen in our system, such as when we're pregnant, and we know that pregnant women don't have higher rates of breast cancer. So I think, again, this is an area that a lot more work needs to be done to untangle the precise connection between estrogen and estrogen receptor positive cancer, right? Because the trials don't really bear out the connection there when small amounts of estrogen are given. So I just want to say, like, from my perspective, I think for women who fail, who are long past their treatment, they're survivors of breast cancer, and they fail non-hormonal treatments, it should never be completely off the table. And I think in the future, it will not be off the table for them to consider low doses of hormone replacement. I just think we need to advocate for more research, because you're right, these women are suffering and often in silence, or often not being given the tools to manage things non-hormonally either. And that's really unfair.
And I think that's where patients talking to you will probably derive a lot of benefit, because I think sometimes they may be expressing these physical complaints or physical concerns to their oncologists. And their oncologists are probably sitting there saying, well, your rate of breast cancer's recurrence is significantly reduced because of this. That's kind of the side effect that you have to tolerate. It's a trade-off. Right. But maybe that trade-off doesn't have to be so harsh. So I think it does require all of us sort of crossing our silos to be working together to address these concerns that may fall sort of out of the traditional realm of medical oncology, but more into, like the whole gynae, but like female health. And I think you're absolutely right. I think to say that estrogen causes breast cancer, or estrogen is always linked to breast cancer, is totally an oversimplification. And that is just not true for, some breast cancers. So I do think a lot more research needs to be done. And I think it is an often neglected but real topic that women suffer from.
Absolutely. And I have a final question, and it's a bit of a loaded question. So answer this in the best way that you feel you can. But what would be your number one piece of advice for women when it comes to promoting their own breast health?
I would say my number one message to anyone who's listening today is take your breast health seriously. So start by doing monthly self-breast exams. And if you are 40 or above, then please self-refer or talk to your family doctor or your nurse practitioner, but self-refer and get enrolled into the Ontario Breast Screening Program. And I think those are probably the best things that you can do for your breast health.
Excellent. Such good advice. It's been a pleasure. I've learned so much from you today. I know that our listeners are going to really take a lot away from this. If we have helped women go and get that mammogram, introduce themselves to the world of breast cancer screening, it's not as scary and awful as it can be made out to be. It's actually a very comforting feeling.
Absolutely.
To know that someone is watching you and that you have the tools, and that we're so lucky to live in a society where we have the opportunity to have screening.
Absolutely.
So thank you for being a guest on Medsplaining today. I really appreciate your time and your expertise. We'll have to have you back for part 2.
Thank you so much, Jennifer. This has been great. I think you're a wonderful interviewer, and I think we've given a lot of information to everybody.
Thank you.
Thank you.
Thanks for listening. Don't forget to follow us on Instagram, Facebook, LinkedIn, and TikTok at Medsplaining. If you have any questions, shoot me a DM. And if you'd like this episode, the best thing you can do is tell a friend or rate and review it wherever you listen to your podcast so other women can discover it. And don't forget, if you're listening to this, you may be happy to know that we video every single episode, so you can watch it if you prefer on YouTube. See you next week. Medsplaining is produced by Ghost Bureau. Thank you for tuning in to Medsplaining. While we strive to provide accurate and insightful information, this podcast is not a substitute for professional medical advice, diagnosis, or treatment. The opinions expressed by our host and guests are their own and should not be interpreted as medical advice. Every individual's health situation is unique, and it is crucial to consult with a qualified healthcare provider regarding your specific concerns and conditions. Additionally, any links, resources, or references mentioned in our episodes are provided for informational purposes only and are not sponsored by Medsplaining. The producers and hosts of Medsplaining assume no responsibility or liability for any actions taken as a result of listening to our podcast. We encourage you to use the information presented here as a starting point for discussions with your healthcare provider. Information and references are subject to change based on scientific evidence as it evolves over time. The hosts and producers of Medsplaining are not responsible for future changes to the information and references and assume no obligation to update based on future developments. Remember, your health and well-being are paramount. Thank you for listening, and we look forward to exploring more topics in women's health with you in future episodes.